So, good morning, students. Today we are gonna look into the respiratory system. So, let me share the screen. See, we shall start with the respiratory physiology. Okay. So here now we are going to see what are the basics of respiratory system. Okay. After that, we'll check the lung capacities as well as the lung volumes. Then we'll see the mechanical ventilator. Then we'll move into the disease conditions of the respiratory system. Okay. So what you're going to look in today's class is that we'll look the functional anatomy, classification of airways, lung volumes and its capacities, then oxygenation, ventilation, and other respiratory mechanics. Okay. So first, the functions of the nose. The main function of a nose is the olfaction. It helps in the smell. So which is the nerve that helps in the olfaction? That's the olfactory nerve, right? So in your prometric examination, what you want to understand is that olfaction, it's the olfactory nerve. Okay. And the nose act as an air condition which when the air is inspired and it is filtered, it is heated and it is humidified. That is the main function of the nose. And it is also having those brush like cilia which helps in the what in the filtration of the air. Large dust particles will be filtered from the nose itself, and it's also important for your vocal resonance. Okay, your vocal resonance is also controlled by your nose. Okay, there is it. The point is, it is the limbic system of the brain which controls the olfactions. Clear? Now, what are the functions of the nose? See, as we have already said, the main functions of the nose is the olfaction, and it secretes the saliva. The mucosa will be secreted in the nose. Okay, and there is also a lysosome which is present in the nasal secretion, which kills the bacteria and the viruses. See, look into these picture. Look into this picture. This picture will help you to understand what is there in the inside nose. There is superior concha, middle concha, and inferior concha. Inferior meatus, middle meatus, and superior meatus. Just leave it. No questions will be asked. See the classification of the what are the anatomical structure of the nose. Just leave. Just leave all those things. The only thing what you have to know is this. This is the picture of what is needed. Okay, so this is the nose, and we have a cartilage here. Okay, then have the nasal bone. Okay, this is the nasal bone. And then we have a frontal sinus. There are four sinuses. There are four sinuses. So there is a maxillary sinus, ethmoid sinus, sphenoid sinus, and a frontal sinus. Okay, there are four sinuses: ethmoid sinus, maxillary sinus, sphenoid sinus, and frontal sinus. Those are the four sinuses which is present in the nasal area. Now, what are the functions of the sinuses? So, the functions of the sinuses, it enhances voices, it helps in the humidification and filtration of the air, and uh, uh, there is a catch in here. See, when we inhale the air, for example, if we are having any nose block, when we inhale it, when we forcefully inhale it, all the mucosa which will be present in the nose will be taken back into your sinuses. Okay, so there is a chance, there is a high chance that your sinuses may be blocked. Okay, in that conditions, we'll go with the surgery called as antroconal surgeries. So what we does is that we'll just insert a tip catheter into the sinuses. Mainly, it is affecting the frontal sinuses. Okay, so we'll just make a catheter tipped inserted into these frontal sinuses, and we'll flush it with saline. Okay, that is a procedure which we are giving. Okay, that is a clinical importance in case of sinuses. Okay, so we have meant all these sinuses: frontal sinus, ethmoid sinus, sphenoid sinuses, and maxillary sinuses. There are four sinuses. Okay, now later we have the pharynx. So, what is a see? This is a picture you can see here. See, this is the nose. Okay, this is the nose. The air is coming to. See, when we just take a pen, and insert it through your nose. Where it stops. So that is this area which is known as a nasopharynx. We have, see, pharynx has been divided to three: nasopharynx, oropharynx, and laryngopharynx. Okay, so nasopharynx is the furthermost posterior end of the nasal strip. So when you insert when you insert a pen in through your nose, it will reach into your nasopharynx. When you insert a pen through your mouth, it will reach into your oropharynx. Okay, so and there is a pharynx which is beneath or posterior to your larynx, which is known as a laryngopharynx. Okay, so that is the nasopharynx, also oropharynx, and the laryngopharynx. Now, there is a structure known as epiglottis. So actually, we have two epiglottis. Now, here what we are going to see is the second type of epiglottis. See, this is your mouth, like this, right? So this is the nose. Okay, this is your nasopharynx, and here the mouth will be connected into your oropharynx. Okay, this is the structure. Here we have two division. Okay, one is the one goes into your lungs. This goes into your lungs, and this to your esophagus. Clear? See, we have epiglottis. We have a epiglottis here, and we have actually there is this is the main epiglottis. This is actually called as uvula. So this is epiglottis. So what happens then? See, when we intake a food, when we are intaking a food, when we swallow it, when we swallow this condition, when we swallow this epiglottis will be closing the respiratory tract, and the food will be going into your what into your esophagus, right? Okay, that condition is known as deglutation apnea. Deglutation, glutation apnea, deglutation apnea. So when we swallow something, it will close your epiglottis and it will go into your this esophagus, right? So when you are not eating anything, or when you are not, it's not eating, when you are not swallowing anything, this epiglottis will be closing your mouth. Okay, this epiglottis will be closing your mouth and enhancing the passage of air through your nostrils to your lungs. Okay, clear with this? So yeah, that is why when you tamper something, when you play with your food, when you eat and when you smile and eat, when you laugh and eat, what happens is that the pressure inside the epiglottis won't be able to control it properly. Thus, it automatically opens, and the food may enter into your lungs, precisely into your larynx. Okay. So those are the functions of the pharynx. It protects the lower respiratory tract. Okay, that is the main function of the pharynx. So this is a clear picture of it. Just no need to understand all these anatomy for your prometric examination. Just leave that. Okay. So next is the larynx. What is larynx? It helps in the what? It helps you to uh, speak, right? So next is the trachea. So why I am skipping all these things is because no questions will be asked, and that's just there is a vocal cord here, and we have two nerves, which is laryngeal nerve. Okay, and one more thing what I would like to say is that there are two laryngeal nerves. Okay, two laryngeal nerves are the see, in case of thyroidectomy, what we check is that we'll check with the patient. See, first thing during thyroidectomy, what we check is that the edema over the area. Soon after the surgery, we have to check the edema over the area. After that, we'll ask the patient to talk. If the patient is talking properly, there is no problem. Otherwise, if there is a hoarseness of sound, if there is a hoarseness of sound, there may be a unilateral laryngeal nerve compression or damage due to the procedure, due to the surgery. Or if there may be a bilateral laryngeal damage, which involves what? which involves the muting of the sound, because the patient won't be able to talk. Why? Because why the patient won't be able to talk? Because the laryngeal nerves have been damaged. Okay, the laryngeal dam maybe is damaged due to the surgery. Okay, so after the surgery, we have to check that, and after 6 hours, you have to check for the calcium level. Why? Because accidental parathyroidectomy can also be happened in the case of thyroidectomy. So that is a clinical catch here. Okay. Now, what are the functional anatomy of the trachea? See, the trachea is 18 mm in diameter, 11 in. No questions will be asked. Just your trachea. The trachea, point that we have to know is the bifurcation of the trachea. The area where the trachea bifurcated, this point is known as carina. Okay, this is known as carina. And we have tracheal rings over here, which are made up of cartilages. Okay, so these are the cells of the trachea, which is globe. Let's just leave that. No question. Now, bronchus. You know the trachea. The trachea will be divided into two. Okay, this is a primary bronchi. So then it enters into your lungs. Okay, from here it divides into secondary bronchi. Right, this is a secondary bronchi. It again divides into tertiary bronchi into quaternary bronchi, into next generation, and it divides and divides and divides up to 23rd generation. Okay, to 23rd generation, it divides. Now we have anatomical dead space and physiological dead space. Clear. So anatomical dead space is the area up to 16th generation. So the trachea divides and divides. So what do you mean by anatomical dead space is that the air won't be able to pass. The air won't be able to pass from trachea through like this. Okay, the air won't be able to pass like this. So this is up to the 16th generation. After the 17th generation, when it again divide, the air will be able to pass through here. Okay, the air can be pass through here. So that is the difference. This is important. Okay, the generation gaps. So that bronchus divides into a 23 generation. There are 23 divisions for these bronchus. Okay, bronchi will be divided and 23 generation, 23 divisions happens into these bronchus. There are two types of uh, divisions. First one is anatomical dead space, and second one is the physiological dead space. So, what do you mean by anatomical dead space? Up to 16th generation, okay, up to 16th generation, the air won't be able to pass through the bronchus. Okay, like this. But after it, the air will be passing like this. Okay, the air can be passed like this. This condition is known as the conduction takes place. Now, what happens in the clinical condition is that due to any COPD, due to any bronchitis, or due to any obstruction, even after the 17th generation, the air won't be able to pass like this. That condition is known as physiological dead space. Clear? Fine. Okay, this is that condition. Okay. No, we have cell types and its function. See, type 1 alveolar, we have alveolar cells. Don't confuse all these things. Just for the prometric examination, I'll say like the bronchus will be divided to up to 23 generation. At the 23 generation, we have the alveolar sac. Okay, in the alveolar sac, when taken it, we have the alveoli. So this is the alveoli. This alveoli helps in the what gaseous exchange. So the air which we'll inhaling will be reaching this alveolar space. Okay, and in the alveolar space, we have the capillaries running through here. So the oxygen which is present in the higher concentration in the alveoli, will be moved to the capillaries, which is having a lower pressure. So, there is a pressure gradient difference, right? So, when there is an increase in the oxygen in the alveoli, it will be moved into the lower areas of the alveoli. So, so the increased pressure of alveoli Increased pressure of oxygen in the alveoli will encompasses the movement of oxygen into the cell into the this capillary system. And the increased pressure of carbon dioxide, there will be an increased pressure of carbon dioxide in the in the capillaries, and there is a decreased carbon dioxide in the alveoli. So due to these pressure gradient difference, the carbon dioxide will be moved into the alveolar stream. This is how internal respiration takes place. See, we have external respiration, internal respiration, and cellular respiration. Okay, there are three types of respiration: internal respiration, and the cellular respiration. So external respiration is between the atmosphere and the nose. So the oxygen from the outermost area will be taken up by the nose and the carbon dioxide will be released. That is an external respiration. Internal respiration is this one between the alveoli. Internal respiration is between the alveoli and the this one. Your this alveoli and the circulation within the capillaries. That is internal respiration. And cellular respiration means the capillaries will be here, and here there will be a cell. So the cell need oxygen, right? So the oxygen from the capillaries will be moved towards the cell, and the carbon dioxide inside the cell will be moved towards these capillaries. So that is known as cellular respiration. Okay. Now we have surfactant. You know the surfactant, right? Uh, At the when the baby is in the form of a fetus, after 36 weeks of gestation only, the surfactant will be produced inside the lung, or the proper functioning of the lung will happen. What happened before that? The surfactant won't be there. So in that condition, we have to replace the lungs with surfactant. And this is not in case of babies itself. In case of ARDS, acute respiratory distress syndrome, if the person have drowned, okay, there are a lot of conditions when there is a collapse of alveoli, atelectasis. In that conditions, we have to do surfactant replacement therapy. Which are the surfactants in in our lungs? It is lecithin and sphygmomyelin. So lecithin and the sphygmomyelin are the two surfactants in the human body. Okay, just understand that lecithin and sphygmomyelin are the. Now, what are the functions of surfactant? See, for the alveolar sac. See, in the alveolar sac, we have some surfactants. Okay, it's just a material inside the alveolar sacs. So this will prevent the alveoli of prevent alveolar collapse. Okay, it reduces the surface tension. Okay, it reduces the surface tension, thus by collapse of the alveoli. It improves alveolar stability. Okay, and it keeps alveolar dry. Okay, because of the by opposing the water movement. Just understand that it's keep the alveolar dry, and it maintains the alveolar stability, and it reduces the surface tension. So those are the functions of the surface. Now we have lung volumes and lung capacities. Let us look into that. What are these lung volumes and what are these lung capacities? It may vary according to age, gender, height, weight, all these things. But basically, we'll check what are these conditions. We have four lung volumes and four lung capacities. Clear? Four lung volumes and four lung capacities. First and the foremost thing is the tidal volume. So tidal volume is the normal volume of air that we inhale and exhale. Okay, it's a normal air that we inhale and exhale, and the normal tidal volume is 500 ml. Just study this one. This is the accurate one, but you don't need that. No questions will be asked like that. Okay. And the tidal volume, it is 500 ml. And what is tidal volume? Kindly write the lecture notes. Okay, it is the average amount expired after normal inspiration. Okay. Or you can say that it's the normal inspiration and expiration gas. The tidal volume, it's the average amount. It is the average amount expired after normal inspiration. Tidal volume. It is a normal amount that is expired after normal inspiration. Okay. That is a tidal volume. Okay. Next one. Next one is expiratory reserve volume, ERV. Expiratory reserve volume. So expiratory reserve volume means it is air forcefully expired after normal expiration. Okay. So when you do an expiration, you know what is inspiration and expiration, right? Inspiration means taking the air inside the body. Expiration means releasing the air outside the body through your nostrils. So what is expiratory reserve volume? Expiratory reserve volume means after after a normal expiration, okay, after a normal expiration, the amount of air that you can expire, forcefully expire from your lungs, that is the expiratory reserve volume. Okay, that is the expiratory reserve volume. So the amount is 1000 to 1200 ml. Expiratory reserve volume is the amount of air that can be forcefully expired after normal expiration. Kindly write these down. Forcefully expired after normal expiration. That is expiratory reserve volume. And it is 1000 to 1200 ml. Clear? So, the air, you have forcefully expired an air. Okay, you have forcefully expired an air from your lungs. Even though you have forcefully expired air from your lungs, even though your lungs will be having some sort of what, uh, some sort of air inside your lungs, right? So that air will prevent the collapse of the alveoli. Okay, so that is the residual volume. Okay, that is known as a residual volume. So the lungs, the air which is remaining inside the lungs after the forceful expiration. Okay, air, air which is inside the lung, air which is inside the lung. Okay, it is a air which is inside the lung after the forceful expiration. Air which is inside the lung after forceful expiration. That is the residual volume, and the residual volume is also 1200 ml. So the residual volume will prevent the atelectasis of your alveoli. Okay, 1200 ml. That is a residual volume. So we have tidal volume, expiratory reserve volume, residual volume, and last one is inspiratory residual volume. So it's just the opposite of ERV. What was ERV? It was forceful expiration after normal expiration. What is IRV? It is forceful inspiration after normal inspiration. So when you are normally inspired, after that, how much air you can forcefully inhale? That is the IRV. Forceful inspiration after normal inspiration. That is IRV. Inspiratory residual volume. That is 3000 ml. Any doubt in lung volumes? Guys, anybody having any doubt in lung volume?
What's it for? No, sir. Anybody?
Yes, Rajesh. Any doubt?
No, sir.
No. Okay, fine. So that is lung volumes. Next, we are moving into lung capacities. Okay, next is lung capacities. Okay. So here you can see any two or more volumes added together, you will get a capacity. Okay. Any two or more volume added, you will get a capacity. See the point. What is total lung capacity? What is total lung capacity? Total lung capacity is the volume of air in the lungs at the end of maximum inspiration. So you have inspired your maximum. See, when you're going to swimming, okay. So what do? You will take the maximum air which your lungs can hold. Okay, that is your maximum inspiration that you're taking. That is a total lung capacity. Okay. That is the total lung capacity. So in the total in lung capacity, what all things will be added? See, residual volume will be there, right? 1,500, 1,200 ml residual volume will be there. Then so your ERV will be there, plus your IRV, plus your tidal volume. So when you combine all these things, you will get the total lung capacity. Okay, so it is 1,000. What will be the amount of total lung capacity when you add all those things? Like when you add the 500, 1,000, 3,000, 1,200, what will be the amount? It is 5,500. So that is your total lung capacity. Okay, next is your vital capacity. So vital capacity means it is the air forcefully expired after forceful inspiration. Okay, force vital capacity means air forcefully expired after forceful expiration. So when you take the maximum air inside and then you expire the maximum air outside. So that is your lung capacity, which means it's a maximum how you can and inspire and maximum how you can expire. That is your total lung capacity. Okay, so it is nothing but adding your IRV plus TV plus ERV. It will be around 4,500. Okay, IRV plus TV plus ERV. So that is your vital capacity. Okay, and there is one more thing which is known as inspiratory capacity. So those are the four: total lung capacity, vital capacity, inspiratory capacity, and functional residual capacity. So inspiratory capacity is the amount of air inspired after normal expiration. Amount of air inspired after normal expiration. So amount of air inspired after normal expiration. So it is around 3,500 ml. It is uh, 3,500 ml. It is what inspiratory capacity is IRV plus TV. IRV plus TV. That is inspiratory capacity. Okay. And the last one is functional residual capacity. So functional residual capacity is amount of air left in the lung after normal expiration. Okay. Amount of air which is left in the lungs after normal expiration. So that is 2,300 ERV plus RV. That is ERV plus RV. Okay. So those are the lung volumes and lung capacities. That you have to study very hard because questions may ask from lung volumes and lung capacities. See, study this properly, then only we will be able to take the mechanical ventilators. Mechanical ventilators are all on all the mechanical ventilator functions are dependent on these lung volumes and lung capacities. So spirometry is the machine which is used to calculate the lung volumes and capacities. Just understand that we don't want to go into deep in the spirometry. We are not respiratory therapist. So it's the basic spirometry which we are doing. So just leave it. No, we don't want these things. Okay. So dead space we have said what is anatomical dead space, what is physiological dead space. That's enough. See, we have studied this, right? Inspiratory muscles as well as expiratory muscles, you know well. And see this one, clinical points. The endotracheal tube of the adult should be just 1 to 2 centimeter above the carina. See, this is the carina, and it should be 1 or 2 centimeters up. Your into this endotracheal tube should be placed at this point. Okay, just 1 to 2 centimeter above the carina. Why? To enhance the easy passage of air to both lungs. So I think the basic anatomy is clear, right? Any doubt on the basic anatomy? Guys, are you having any doubt on the basic anatomy?
No, sir.
Yes, sir.
Okay. Now, now what we are having left is the basics, the breath sounds. Okay. So let us see what are the breath sounds. So the breath sounds, breath sound. Okay. See, first we'll see the normal breath sounds. Okay. First we'll see the normal breath sound. First one is bronchial sound. You all are nurses and you all are very well aware of what are breath sounds. You will be handling with a stethoscope, right? So when you auscultate your lungs, you can find these conditions. Okay. So these things will be very familiar with you, even though for the exam point of view, I'm explaining it. Okay. So we have bronchial sounds, we have vesicular sounds, and we have bronchovesicular sounds. So those are the three normal sounds. Bronchovesicular sounds. Okay. So three sounds are the bronchial sound, vesicular sound, and bronchovesicular sound. In bronchial sound, what happens is that the expiratory sound will be more than the inspiratory sound. That is the difference. Okay. In vesicular sound, the inspiratory sound will be more than the expiratory sound. And in bronchovesicular sound, inspiration sound will be equal to the expiratory sound. Simple. Got it? So the bronchial sound, the vesicular sound, and the bronchovesicular sound. So those are the three normal breath sounds. Now we shall move into the abnormal sounds. Okay. We have crackles. Okay. So fine crackles, fine crackles. First sound is a fine crackles. So fine crackles mean the airway with fluid. The your airway will be filled by fluids. Airway will be filled by fluids. Airway will be filled by fluids. That is that is a sound, fine crackle sounds. Okay, here how you can understand is that just take your fingers in between your thumb finger and your index finger and just rub it, just rub it. So what is the sound that you're hearing? That is the sound of a fine crackles. Okay, just take a strip of finger, just take a strip of hair in your hand, both in your index finger and middle finger, and just rub it. So the sound that you're hearing, that is a fine crackle. Okay, and it can be heard at the height of inspiration. Okay, it can be heard at the height of inspiration. You can hear it at the height of inspiration. Okay, in case of pneumonia, you can hear the sound. Pneumonia, it's a condition. Next condition is horse crackle. Coars, horse crackle. Horse crackle. Okay. Here the airway was filled with fluids. Here the airway is filled with mucus. Okay. Crackles will be there. COPD is a condition. Majority of the patients who are uh, coming into your hospital will be airway will be filled with mucus. COPD, the main condition. So you can hear the crackle sound. Next is the wheeze, or you can hear it as rhonchi. Can hear it as rhonchi. It is due to narrow airway. Okay, it is due to narrow airway. It is due to narrow airway. In case of asthma, bronchial asthma. Okay. And the fourth sound is frictional rub, plural frictional rub. You can call it as plural frictional rub, frictional rub. So what is pleural frictional rub? See the lung. Okay, there is a covering for nostril. There are two coverings for the lungs. So when the fluid when absent in between these layers will make the will make the layers to come closer. Okay, then this sound will be heard. What are the coverings of the lungs? Anybody? What are the coverings of the lungs? The layers, the layer which are covering the lungs. It is visceral and parietal layers. So when there is a decreased amount of fluid inside the visceral and parietal layers, it may leads to a frictional rub. Okay. So these were the basics of respiratory system. Next, we'll move into the pharmacology, the respiratory pharmacology. The respiratory pharmacology. Okay. So the first condition, first medicine, it is bronchodilators and anti-asthmatics. First one is your bronchodilators, bronchodilators and anti-asthmatic, bronchodilators and your anti-asthmatics. What is the function of that? What is the function of these bronchodilators? The name itself indicates it will reverse the bronchoconstriction. Okay, it will reverse the bronchoconstriction. The action, mechanism of action of bronchodilators is that it will reverse the bronchoconstriction. Okay, reverse the bronchoconstriction. It will reverse the bronchoconstriction. Okay, and also it stimulates the beta adrenergic sympathetic nervous system. Stimulates beta adrenergic sympathetic nervous system. So what happens when these beta adrenergic sympathetic nervous systems are stimulated? It relaxes the bronchial smooth muscles. Okay. See, in our bronchus, we have alpha receptors and beta receptors. Okay. This stimulates beta adrenergic nervous system. Thus, it causes smooth muscle relaxation. Bronchial smooth muscle, bronchial smooth muscle relaxation, smooth muscle relaxation. Okay. That is the main function of the bronchodilators. I'll explain it once again. Where the medicine which we are dealing is with bronchodilators and anti-asthmatics. So what is the action of these medicines? It will reverse the bronchoconstriction. Okay. And it also acts on the beta adrenergic receptors. Simply beta receptors. See guys, in the bronchus, okay, in the bronchus, which is inside the lung, we have beta receptors and alpha receptors. In in these bronchus. Okay, so what is the function of these bronchodilators? These bronchodilate will stimulate the beta receptors. Okay, and in the cardiovascular system, we have studied the beta blockers, right? Okay, we have studied about the beta blockers. So what happens? The beta blockers. The beta blockers will. What will the beta blockers do? The beta blockers will decrease the blood pressure, right? So here is a catch. See, there are beta receptors in lungs and there are beta receptors in heart also. Hmm? So when the beta blockers are used in for the heart, for the control of your hypertension, some conditions, the beta blockers will affect the lungs and it leads to what? Respiratory distresses. Fine. And it can happen in the vice versa also. When the beta adrenergic stimulants are used as a bronchodilators, there is a chance it may increase your hypertension stage. Clear? So there is a when the questions comes like that, you have to think in this manner. If the beta blockers, the beta receptors have both action in respiratory system as well as in your cardiovascular system. Clear? Now we'll see all each and every medication. So we were talking about the respiratory medicines. In that first we were talking about the first medicine, that is a bronchodilators and the anti-asthmatic. That is the classification of the medicine, and what is the action of that? It will revert the bronchoconstriction and stimulate the beta adrenergic receptors. Fine. So that was action. Now we shall see each and every drugs which comes in the bronchodilators. Okay, so the first drug which comes in the bronchodilator is beta agonist. Beta agonist. What are the examples? The beta agonist example. They are our epinephrine, then terbutalin. So those are the beta agonist receptors. So what this beta agonist receptor does? So as the name itself indicates, it acts on these beta receptors. Okay. These beta agonist medicine, the epinephrine and the terbutalin will act at the beta adrenergic receptors in the bronchus. Okay, I have already said that there are beta receptors and alpha receptors in the bronchus. So these medicines will act on the beta adrenergic receptors in the bronchus and it will inhibit the histamine release by the smooth muscles. Okay, it will prevent the release of histamines by the smooth muscles. Okay, this will prevent the release of histamines. What are histamines? Histamines. What are histamines? When in the burns we have studied histamines, interleukins, TNF, all these are inflammatory mediators. So when there is inflammatory mediators, it will leads to bronchoconstriction. So when the beta agonists are given, these will prevent these inflammatory mediators, prevent the release of these inflammatory mediators from the smooth muscle. So that is a function of beta agonist. Clear? Any doubt?
No, sir.
Okay. Second one is xanthines. Second one is xanthines. Okay. So these xanthines will act as it act at the bronchial smooth muscles. Okay. Xanthines will act at bronchial smooth muscles and decreases spasm. It will decrease the bronchospasm. It will decrease the bronchospasm by acting on bronchial smooth muscle. It will decrease the spasm on bronchial. It will act on these bronchial smooth muscles and it decreases the bronchial spasm. Example is the deriphyllin. Okay. So what is the clinical significance of the deriphyllin? When deriphyllin is taken, the heart rate may be increased, or the patient with tachycardia, severe tachycardia, deriphyllin is contraindicated. We won't give injection deriphyllin to those patients who is having a heart rate more than 100. Okay. And even if the patient is having a 50 something your heart rate, you can simply can give the Derafil because it will help in the relaxation of the lungs as well as it increases the heart rate. Okay, so those are xanthines. It acts on the respiratory bronchial muscles and decreases the bronchospasm. Third one is anticholinergics. Third one is anticholinergics. Third one is anticholinergics. So as well as the name itself indicate what is it cholinergics. So it decreases the acetylcholine effect at receptor cells of the bronchial smooth muscles. Okay, it decreases the acetylcholine at the bronchial smooth muscles. The medicine is ipratropium. Medicine is ipratropium. Okay. The fourth medicine is leukotriene receptor antagonist. Leukotriene receptor antagonist. Leukotriene receptor antagonist. Leukotriene receptor antagonist. What's the function? Same function. It decreases the bronchoconstriction. It decreases the bronchospasm or the bronchoconstriction. Example: the medicine is montelukast. Have you heard about this Montelukast? Montelukast. So montelukast is the medicine. Leukotriene receptor antagonist. And what are the main side effects of these bronchodilators? So the main side effect of these bronchodilators are it leads to palpitation, dizziness, hypertension. Kindly note hypertension. Why? Because it stimulates the beta stimulants. It stimulates the beta cells or the beta receptors. The main side effect of the bronchodilators are it causes hypertension. So the bronchodilators like these medicines is contraindicated in patients with hypertension. So dizziness will be the palpitation will be the hypertension and CNS stimulation. Okay. So those were the medicines in the bronchodilators. Second classification. Second medicines are mucolytic agents. Mucolytic agents. Mucolytic agents and expectorants. Mucolytic agents and expectorants. So what are mucolytic agents? Mucolytic means it will loosen the mucus, and expectorants mean it increases the cough. Okay, so this mucolytic agents mean it liquefy the secretion, liquefy the mucuses, and expectorant mean it increases the cough. Okay, the medicines are acetylcysteine. Examples are acetylcysteine, N-acetylcysteine, which is an antidote of paracetamol. This is acetylcysteine. So, which increases the cough, the expectorants. That is guaifenesin. It's an expectorant. Then potassium iodide. Potassium iodide. Potassium iodide. N-acetylcysteine, potassium iodide are the examples for mucolytic agents and expectorants. And the main side effects is that it causes bronchospasm and GI irritations. Okay, why bronchospasm? Because it increases the why bronchospasm? Because it increases the cough and the mucus, the secretion will be increased. Okay, thus it may lead to bronchospasm. Okay, third drug. Third drug is your antitussives. Antitussives. TUSSIVES, antitussives. So antitussives are the third group of medications. So it suppress here the expectorants are the medicines which increases the cough so that the maximum mucus is expectorated or released out of the body. Whereas the antitussives are those medicines which suppresses the cough. Okay, antitussive suppresses cough. Example. What are the example? The Benadryl cough syrup, right? The Benadryl cough syrup. Benadryl. It is an antihistamine antitussive. Okay. Benadryl is an antihistamine antitussive. Antihistamine. Then what? Then codeine. Codeine. It's an opioid. Codeine is an opioid which suppresses the. And in which cough we'll give the antitussives? We will only give antitussives if it is a dry cough. Okay. Only in case of a dry cough. Okay. We'll only give it in case of dry cough. Clear? And what are the main side effects of these antitussives? It causes DNS suppression. See, since we are using codeine, which is an opioid analgesic, it may lead to CNS depression. CNS depression. Then dry mouth due to anticholinergic effect. Next one, fourth medicine group of medicines are opioid antagonist. Opioid antagonist. So what are the functions of opioid antagonist? See, agonist means same action. Antagonist means opposite action, right? So agonist is same action and antagonism is opposite action. So it will reverse the respiratory depression. So opioid antagonists are the medicines which reverse the respiratory depression which is caused by opioid overdose. Okay. So when a person is taking an increased amount of codeine and there is a CNS depression, in that condition we will go for opioid antagonist. Okay, naloxone sodium. Naloxone, it is an antidote of morphine. Naloxone. Next, fifth one, that is antihistamines. Fifth one is antihistamines. So it will block the action of histamine. Okay, at the H1 receptors. So simply it blocks the histamines. Okay, it will suppresses the histamine function. Example is cetirizine. Cetirizine, antihistaminic function. So what happens when you take cetirizine? You have drowsiness, dizziness, dry mouth, and all those things. So as a nursing manager, what you have to do is that a gum candy for salivation can be given, and the food have to this antihistamine can be taken along with the food or the milk to prevent the GI irritation and so on. Yeah, that is a antihistamines. Sixth medicines is anti-tubercular drugs, TB drugs, TB drugs. See, we have first line drugs, okay, first line drugs, and we have second line drugs. Guys, this is important. Okay, majority of the questions will be in and around the tuberculosis. First line drugs and second line drugs. See, Have you heard about Pepsi? It's name like that, Pepsi. R for rifampin, rifampicin, rifampin or rifampicin. E for ethambutol. P for pyrazinamide. S for streptomycin. I is for isoniazid. Okay, so these are the medicines for the tuberculosis. Rifampin, ethambutol, pyrazinamide, streptomycin, and isoniazid. Okay, now we have to understand what are the complications or what are the nursing management that we have to you have to check when we are giving these medications, right? So first, rifampin. So what are the mainly what are the side effects of these medicines? Okay, the side effects or which area it is affected. The main thing that the questioners will be asking about the side effects of each and every medicines. So what is the main side effect of rifampin or rifampicin? It will cause orange color, orange color in your sweat and in your urine. Okay, sweat and urine will be in orange color. That is the main complication of or a side effect of the rifampin. Okay, so the patient who is complaining about orange color in the sweat, or when you have to explain it to the patient who is taking rifampicin that your sweat as well as your urine will be in the orange color, that is a side effect of this medicine. You don't have to panic. Otherwise, what happens is that if the patient is wearing a white shirt and if the person sees orange discoloration in the shirt, and the patient may get panic, or even the urine is in the orange color, the patient get panic. Okay, so this is the main side effect of the rifampin. Next is the ethambutol. Ethambutol causes optic nerve, your eye, optic nerve toxicity. Okay, optic nerve toxicity. It causes optic nerve toxicity. Okay. Next is pyrazinamide. Pyrazinamide will causes yellow skin, yellow discoloration of the skin, yellow discoloration of the skin. Okay. Then streptomycin, famous streptomycin for ototoxicity. Ototoxicity. Your this vestibulocochlear nerve. Ototoxicity. It causes ototoxicity and also it may causes nephrotoxicity. Your kidneys also nephrotoxic. It also causes nephrotoxicity. Okay. Isoniazid. See, the isoniazid will cause vitamin B12 deficiency. Okay, vitamin B12 depletion. Mainly, it's not deficiency. It causes depletion. Vitamin B12 depletion. And the isoniazid also inhibit the phenyltoin mechanism. It inhibits the phenyltoin mechanism. And it also cause, since the vitamin B6 depletion is there, it leads to peripheral neuritis. Okay, peripheral neuritis. Okay, so those are the main side effects of these drugs. And the second line drugs are capromycin, capromycin, and cycloserine. Capromycin and cycloserine. So these are the two second line drugs. Just have to study the first line drugs and its side effects. Clear? Any doubt?
No, sir.
Guys, any doubt on it? Okay.
No, sir.
Okay, fine. Now we'll move into the mechanical ventilator. Mechanical ventilation or mechanical ventilator. You know what is mechanical ventilators, right? So we basically see the mechanical ventilator of this classes is a longer portion, so we don't want to emphasize on all those things. We'll just emphasize on a prometric examination. Okay. So the mechanical ventilators are mainly divided into two types: negative pressure ventilator and the positive pressure ventilator. See, pressure pressure is inversely proportional to volume. Like when the pressure increases, the volume decreases. That is a basic concept in this. How your balloon works. That is a basic concept of ventilation, or basic concept of your lung. When the pressure increases, the volume decreases. Now, we have two types of ventilators: negative pressure ventilator and positive pressure ventilator. See, negative pressure ventilator means when a patient is lying down like this. Okay, this is a set, and this will be connected. A ventilator will be connected on the body, on the chest, the thoracic area of the patient, and a pressure will be given to this area. Okay, then what happens? The when the pressure is when the ventilator pulls the patient's thorax into the outer area, the volume inside the lungs will increases. Thus, the pressure will be decreased. And according to that condition, the air which is outside the area will be sucked into the patient's body. Okay, this is the functioning of the negative pressure ventilator. Basically, it was used. It is known as iron lung machine. Iron lung machine. The machine. This machine was known as iron lung machine. It was mainly used in polio condition, poliomyelitis. Okay, now we don't use these negative pressure ventilators. All we use is the positive pressure ventilator. So, what is positive pressure ventilator? A patient is here. We'll insert a tube into his mouth, through his mouth, which is the endotracheal tube, and we'll give positive pressure to that. Okay, so we will introduce air into the patient's lungs. Okay, that is a mechanical positive pressure mechanical ventilator. Okay, and we have some different types of positive pressure ventilators. First one is pressure cycled ventilator. Okay, pressure cycled ventilator. We have pressure cycled ventilator. We have volume. We have volume cycle ventilator, and we have time cycle ventilator. Clear? What is in the pressure cycle ventilator? In the pressure cycle ventilator, we will focus on the pressure of the air which we are giving into the patient. Okay. This pressure cycle ventilator is for short-term use. Okay, so pressure cycle ventilator is mainly for atelectasis. Due to the during the collapse of alveoli, we have to open the alveoli. That's the main important. That's why we are giving a pressure cycle ventilator to the patient. Okay, second one is the volume cycle ventilator. In this volume cycle ventilator, what we'll do is that we will give the amount of air. For example, if we want 500 ml to be given, that is tidal volume. If we want to give the 500 ml to the patient, we will give the 500 ml irrespective of the pressure. Okay, next one is time cycled. So time cycle means in if we'll be giving the air uh, in a fraction of 20 seconds, okay, or 15 seconds. So that is time cycle. Here time is the component. Here amount of air is the component. Here the pressure is the component. That are the three different positive mechanical ventilators. First is it pressure cycle, volume cycle, and time cycle. Clear? So this what we have dealt already, the lungs and all those things. Okay, you don't want such kind of. Now, what are the indications? What are the indications of these ventilators or the use of mechanical ventilator? ARDS, the main thing, acute respiratory distress syndrome, ARDS. Okay, then trauma to the chest. In case of accidents, acute lung injuries, respiratory arrest, okay, COPD. So if the patient is not able to respire properly, okay, acute respiratory acidosis, okay, acute respiratory acidosis with the carbon dioxide more than 50 mm of Hg. What is the normal carbon dioxide level should be in the body? It is between 30 to 35. Okay, 30 to 35 mm of Hg is the max. It's the normal amount of carbon dioxide which should be present in the body. Okay, if it exceeds the 30, oh, sorry, if it exceeds the 50 mm of Hg, then it is an indication that you have to keep the patient inside the mechanical ventilator. And how you can identify whether the patient is having 30 or 35? It is on the basis of ABG, arterial blood gas analysis. Okay, only the arterial blood gas analysis should be encompassed for understanding the respiratory covered or this a got the pressure of the carbon dioxide in the body. Okay, it is an arterial blood gas analysis. And the pH should be 7 point less than 7.25. What is the normal pH? It is 7.35 to 7.45. That this is a normal pH associated with the blood. This is a normal pH of the blood. If it is less than 3.5, we call it as acidosis. If it is more than 4.5, we'll call it as alkalosis. Right. So we have four conditions in the fluid and electrolyte imbalances, which we will deal when we are dealing with fluid and electrolyte imbalances. Okay. So for a quick glance, let me say like it. If there is an increase in the pH of 7.45, it is alkalosis. If it is less than 3.5, it is acidosis. Now, if there is a metabolic compensation, so metabolic part like the bicarbonate, when there is an increase in the bicarbonate, or a disturbance in the bicarbonate, we can call it as metabolic acidosis and alkalosis on the basis of pH. Whether there is a change in the carbon dioxide. Okay, when there is oxygen is not relevant. Okay, carbon dioxide is relevant. When we are taking ABG, oxygen is not relevant. The point which we are checking is for the carbon dioxide. Okay, so the carbon dioxide condition. It is a carbon dioxide that we are checking into. Clear. So if there is a carbon dioxide content, we can call it as respiratory portion. So respiratory acidosis. Okay. Now, and in case of significant tachypnea, respiratory distress, with the signs of respiratory distress. Okay, and if there is any inhalation injuries to the patient, okay, sepsis, whether there is sepsis, shock, congestive heart failure, neurological diseases such as muscular dystrophy or lateral sclerosis. All these conditions are the indications for applying the patient on a mechanical ventilator. So we have explained the negative pressure ventilator and what are the positive pressure ventilator, the iron lung machine. Okay, so this is the negative pressure ventilator. It was used previously. Now it is not in use. The positive pressure ventilators. So the mechanical ventilators regulates the rate, depth, and other characteristics of the ventilator. So it have to be setted upon the status of the ABG of the patient, body weight, muscle strength, and loss of consciousness. Sorry, level of consciousness of the patient. Okay, just leave all these things. Why I'm just leaving that? It's a practical session. So you don't want to have a practical session. You just have to focus on your theoretical examination purpose of part. So we look into each and every modes of ventilator. Okay. First one is controlled mandatory ventilator. Okay. So what do you mean by controlled mandatory ventilator? The controlled mandatory ventilator means what is that? We'll the kindly write the notes. Okay. Like, the notes which here is a huge one, but you don't have to focus on all those things. Just understand the points what I am saying. You just write it down. That is your exam point of purpose. Controlled mandatory ventilator. So controlled mandatory ventilator means we'll receive a specific volume and rate. It is controlled. It is properly controlled. Kindly write this term. It receives a specific, it receives a specific volume and rate. Okay, it receives a specific volume and rate. That is a controlled mandatory ventilator. Okay, which means I'll give you explanation for that. See, in controlled mandatory ventilator, the patient have to do nothing on respiration. All the lung functions will be controlled by your ventilator purposes, ventilator setting. Okay, we won't allow the patient to respire. That is controlled mandatory ventilator. Okay, we will give morphine or vancuronium, and we will sedate the skeletal muscles. We'll sedate the respiratory muscles of the patient. Okay, we'll sedate the respiratory muscles of the patient so that the patient don't respire by him or herself. Clear? So why we are doing it? We are doing it so that we want to control the respiration. Clear? That is controlled mandatory ventilator. Nowadays, we won't keep the patient in controlled mandatory ventilator. Why? Because if we are keeping the patient in controlled mandatory ventilator, it is very difficult to wean the patient. Okay, weaning means just taking out the patient from the ventilator. So it will be very difficult to wean the patient. That's why we won't keep the nowadays we won't keep the patient controlled mandatory ventilator. But we first we'll move the patient to controlled mandatory ventilator. As the name itself indicates, it is assist controlled mandatory ventilator. Okay. So here what happens is that the client triggers the machine. In the assist controlled ventilators, client triggers the machine so that the rate may vary. Okay, the rate may be varied. The rate means, for example, if we are setting 10, in the next minute it will be 11, or in the next minute it will be 12. That is, a rate may vary. But the amount of volume, the volume will be same. The machine will set the volume like the tidal volume. It will be 400, 450 ml or 500 ml like that. It is not usually, we won't usually keep the tidal volume as 500 ml. You know, the normal tidal volume is 500 ml, but we won't keep the tidal volume as, we won't prefix the tidal volume as 500. It may vary. Okay, it may be 400, 450 or something like that. So that is assist controlled mandatory ventilator. We will keep the patient in the assist controlled ventilator so that the client can trigger the machine. Okay, in case of apnea. Okay. Next is synchronized intermittent mandatory ventilator. Synchronization is this. So what do you mean by synchronization? The ventilator's breath is synchronized with the patient's breath. So this condition is used for weaning. So when we want to move the patient outside the ventilator, we'll keep the patient in the synchronized SIMV mode. Okay, the breath of the patient will be machine and the patient will be synchronized. So what happens in synchronized mandatory ventilator? The patient have to take an initiation of breathing. So when the patient takes an initiation for the breathing, then only the machine will deliver the air. Okay, so otherwise, machine will wait. Okay, when he'll ask for the air, when the patient will ask for the respiration. So patient will wait for that. If the patient is not taking the air, or if the patient is not having an initiation for respiration for a particular period of time, the machine will give it. Okay. Otherwise, the machine, for each respiration, the machine will wait whether the patient have an what capacity to take the air by his own. That is synchronized intermittent mandatory ventilator. Okay. There is one more thing, intermittent mandatory ventilator. Okay. So before synchronized intermittent mandatory ventilator, there is an intermittent mandatory ventilator. Here what happens is that the patient will receive the tidal volume and the number of breaths per minute. Okay. Which means if we can have, but we have setting 10 minutes, 10 respiration per minute, it will be given by the machine. Okay. So SIMV is something more than IFV. Next is the PEEP, that is positive end airway expiratory pressure. Positive and expiratory pressure. Okay. So PEEP mode, they maintain the positive pressure at the end of expiration. Okay, PEEP mode. So what the PEEP mode does is that it maintains a positive pressure at the end of expiration. So when a patient expires the air, even though the patient expires the air, the positive pressure mode what it does is that it gives a positive pressure to the lungs so that it prevents the collapse of the alveoli. Okay, so from then these positive and airway pressure are given to the patient who is on atelectasis. Okay, in order to keep the alveoli open. That is positive airway expiratory and expiratory pressure. Okay, we'll give a positive pressure at the end of expiration. Kindly write this down. We'll give positive pressure at the end of expiration to keep the alveoli open. That is a PEEP mode. Next is the CPAP. See, CPAP means continuous positive airway pressure. It is more or less similar to PEEP. Okay, it is more or less similar to PEEP. But what is the difference? It's that, but it exerts positive pressure throughout the respiratory cycle. What was PEEP? PEEP was giving pressure at the end of the expiratory circle, whereas CPAP is giving positive pressure throughout the respiratory circle. Okay. So CPAP, the CPAP machine, if the CPAP machine, continuous positive airway pressure, the CPAP machine is given as a mask. Okay, it is not an invasive method. It is a non-invasive method. You don't have to keep the endotracheal tube for the CPAP machine. You can just keep it on the face of the patient. Okay, CPAP machine. It's on the face of the patient. Patient. Next, there is another option known as BiPAP, bi-level positive airway pressure. Okay, so BiPAP is also like through your nose as well as your mouth. Both your mouth as well as your nose will be covered. Okay, it is also a non-invasive method. Okay, so the explanations are here. That is what I have said. Now, as a nursing management, what you have to check is that there will be fight or buck ventilator, which means the patient will fight the ventilator. Fight the ventilator means the patient will be bucking the ventilator, which means see the patient will be in the semi-conscious. When the patient is in the semi-conscious state, the patient tries to come out of the ventilator, or the patient may pull the ventilator intubation tube by its own. So that is the main problem with the when we are when we are caring for the patient. You have to check for the fight or the bucking of the ventilator. So in that condition, we'll just sedate the patient. Okay. Now, what are the complications? What are the complications of ventilator? This is important. Okay, ventilator itself is an important portion, and you may see first one was you may get questions from the modes of ventilator. Next, the areas which you can get the questions is from the complications. What are the complications of this mechanical ventilator? First thing, hypotension will be there. Then pneumothorax. Just study these things. That's all. Need not to know what are the physiological changes in between. So if you want, I can explain it. Okay. But there is no point, and that's just a waste of time for your prometric examination. Just study this. What will be the complication? So the hypotential will be the what is the reason for the hypotension? Since the patient is on sedation, it may lead to hypotension. Okay. Next, pneumothorax, air entry, pneumothorax, because the machine itself is giving the air pressures into that. So in that condition, the patient won't check the machine won't check whether there is pneumothorax or not. So as a result, pneumothorax may occur. Decreased cardiac output. Why decreased cardiac output? Since the lungs will be pre-filled with oxygen, pre-filled with all these airs, it won't see the it won't see the cardiac component. That way, it leads to decreased cardiac output. Nosocomial infection. Definitely, if there is an invasive procedure, there will be a hospital acquired infection. Positive water balance because of the positive airway pressure which we are giving. Increased intracranial pressure because when the intrathoracic pressures are increased, it leads to an increased intracranial pressures. Okay, alarm of maybe completion. Sinusitis will be the mucosal lesions, aspiration, GI bleeding. All those things will be the basic problems with these in with these ventilator. Okay, just terminologies. Now, nursing management. How to keep the ventilator ready to receive the case. So first one is you have to check the air and the oxygen connection, ventilators and tube connection. You have to very thoroughly check for all these things. The check the lung tube as well as the check lung. You have to uh, test with the check lung machine so that the ventilator is properly functioning or not. There should not be any loose items. Okay, so connect the servo guard to the patient so that HEPA filters are applied. HEPA filters. HEPA filters. So HEPA filters, when applied onto the lungs, which prevent the virus entry into the lungs of the patient. Okay, HEPA filters are connected. So this is the bacterial filter. It is HEPA filters. It's also connected to the. It's also very efficient for the viruses as well. Okay, the same. With the check, with the complications, what do you have to check? And suctioning. How will you suction? The main thing, how will you suction? Suppose any suction in case of endotracheal tube or mouth, any suction, how will you? We'll check on the how will you do the tracheostomy suction. Okay, this is a tracheostomy opening. Okay, for the patient. So how will you suction? How will you do the suction? First step is you have to pre-oxygenate the patient. Okay, pre-oxygenate the patient to 100 percentage of SpO2. You have to pre-oxygenate the patient with 100 percentage of SpO2. Fine. After that, you have to insert the catheter by switching off. Okay, you have to switch off the suction machine. You have to switch off the suction machine and you have to insert the catheter into your what the suction area. Then in a circulatory motion you have to after keeping after keeping the suction machine into the desired area, you have to switch on the suction machine. Then in a circulatory motion you have to take out the catheter. Okay, in the circulatory motion you have to take out the catheter, and the maximum time for the suction should be less than 20 seconds. You should not cross the suction more than 20 seconds. Soon after you take the suction back, you have to oxygenate the patient. Okay, this is how suctioning is done. Clear? Fine. So, any doubt in the ventilator? Any doubt in the mechanical ventilator? Guys, are you having any doubt in the mechanical ventilator?
No, sir.
No, sir.
No doubt. Fine. Very good. Okay, next is the oxygenation. So, oxygen cannula. First, just one thing you have to understand oxygenation. So, that comes in your fundamentals of nursing. Okay. So simply I want to discuss here is that the nasal cannula, when you are using the nasal cannula, 1 to 6 liters is the flow rate per minute. When it is a simple mask, it is 5 to 8 liters. When non-breathing mask, it is 12 to 15. And if it is a partial breathing mask, it is 8 to 11 liters. And when you are using venturi mask, it's also 5 liters. And there is a oxygen hood for the pediatric persons, which is 10 liter per minute. That is a supply. Okay, so thus we have completed the basics of respiratory system. On tomorrow's class, we'll go into the disease conditions of the respiratory system.